Welcome to the Advancing Surgical Care podcast, brought to you by ASCA, the Ambulatory Surgery Center Association. ASCA represents the interests of outpatient surgery centers of every specialty and provides advocacy and resources to assist them in providing safe, high-quality, cost-effective patient care. As with all of ASCA's communications, please check to make sure you are listening to or viewing our most up-to-date podcasts and announcements.
Hello and welcome to the Advancing Surgical Care podcast. I'm Bill Prentice, ASCA CEO and host of this recording. In this episode, we'll be talking about the challenges of providing anesthesia services in surgery centers today, with two ASCA members who are meeting these challenges head-on. Obtaining anesthesia services has become one of the most complex parts of running a successful ASC today, and striking the right balance between providing high-quality anesthesia care and maintaining financial viability is harder than ever. With provider shortages, anesthesia stipends, evolving regional anesthesia techniques, and scheduling conflicts, ASC leaders are navigating an increasingly difficult landscape. Fundamentally, the country needs more anesthesia providers to meet the growing demand, but that education and training is going to take time. And that's why ASCA is focusing on identifying and sharing the best practices for managing through this challenge. This year's annual meeting and expo is taking place in mid-May, just outside Washington, D.C., and will be held in collaboration with the Society for Ambulatory Anesthesia, or SAMBA. This exciting collaboration brings together ASC clinical and operational leaders with experts in outpatient anesthesia. By uniting these communities, ASCA and SAMBA 2026 will offer a richer, more interdisciplinary learning and networking experience for the entire ASC community. And you can learn more about how to attend the conference on the ASCA website at ascassociation.org. One of the premier sessions will be a panel discussion on managing anesthesia services in ASCs today. And two of those panelists are with me today to talk about how they are innovating and adapting to succeed in this new and challenging environment. Garrett Hilgendorf is the administrator of the Mankato Surgery Center in Mankato, Minnesota. And Brett Maxfield is the CRNA and the principal and founder of Maxfield Health Solutions, a provider of anesthesia equipment and consulting services based in Rigby, Idaho. Garrett and Brett, welcome to the podcast.
Thanks, Bill.
Yeah, thanks, Bill.
So, man, I think it would be helpful for our listeners to have a general sense of your respective operations. Garrett, let me start with you. Can you tell us a little bit about your center, number of ORs, your practice specialties, weekly case volume, and whether you employ or contract with anesthesia providers?
Yeah, we're a multi-specialty surgery center in Mankato, Minnesota. We have a number of specialties from general, GYN, ortho, ENT, GI, ophthalmology, urology, podiatry, and pain injection. So a wide variety. 4 operating rooms. We are considered a metropolitan area, but in a rural setting, kind of the only large ASC in our market. Within our center, we have employed anesthesia providers. So we have CRNAs and 1 medical doctor of anesthesia.
Great. Brett, as I mentioned a moment ago, your practice is working with surgery centers providing both service and equipment fulfillment. Can you tell us about the established surgery centers that you work with, their size, specialties, how they're being impacted by the shortage of anesthesia providers?
You bet. So I have 2 that I have ownership and management direct involvement with. And then I've got about 400 to 450 others that I have involvement with to one degree or another, either working with the anesthesia team, working with the ASC themselves to help with their management, direction, supply chain, you name it, as far as those go. We're a little bit different from Garrett. We tend to stick to the smaller practices. So the office-based practice, the 1 to 2 OR, smaller practices. And a lot of that happens to be plastic surgery, dental surgery, some of those smaller podiatry, things like that, those smaller practices that were pushed out of the hospital during COVID and have started their own thing. Anesthesia is a big deal. Those areas have very small margins. And so as we get a shortage, it makes it really difficult to have those anesthesia stipends to find those good providers while still maintaining financial viability. Several of those facilities have had to get innovative with finding ways to sometimes do without the anesthesia, doing things like oral sedation permits or local anesthesia only, things like that. So it definitely has had an impact. We've been fortunate with the 2 that I own and direct in Idaho, just through connections from having worked in anesthesia previously. We've been able to keep our doors open and moving consistently through those relationships. But some of those others that don't have those established relationships, it's definitely been tougher.
Well, Gary and Brett, we need to take a short break to hear from our podcast sponsor. Stand by and we'll be right back.
This recording is being brought to you by Surgery Partners, a leading owner and operator of ambulatory surgery centers with more than 200 locations nationwide. Surgery Partners collaborates with ASC leaders and physicians to acquire, develop, and optimize surgery center operations and helps ASCs scale efficiently, strengthen performance, and drive long-term growth. To learn more, visit surgerypartners.com.
Garrett, Brett, one recurring theme that I hear from the centers who are successfully managing through their anesthesia challenges is collaboration on scheduling, patient mix, profitability, and more. Brett, let me start with you. Are you also seeing change taking place in the way surgery centers are interacting with their anesthesia providers? And if so, can you give us an example of what they're seeing or hearing?
You bet. One of the things that has been very successful is making sure that these anesthesia providers feel like they have skin in the game, if you will. And so a lot of these smaller facilities have started including the anesthesia providers as partners or in ownership there. And that's been a very good thing for both sides. It makes both parties feel like they're involved and that they're working together for the same goal. And these smaller facilities, that's been something that has really helped because the anesthesia provider is the glue that kind of holds those facilities together. That because you don't have the split departments specializing in different areas, a lot of times those anesthesia providers become your pre-anesthesia testing. They become your post-op follow-up people. Obviously, they're doing the anesthesia in there. They become part of your anesthesia department. They have to be part of your quality assurance department. And so just getting that buy-in from the anesthesia group or the anesthesia provider who's with that, and then having that reciprocal respect and buy-in from the groups has been really important.
Has it been hard to get the surgeons in those facilities to buy into that idea?
To be honest, it hasn't, just because a lot of these surgeons, one, want to be successful, and two, there's a mutual respect in a lot of these areas where the anesthesia providers recognize that the reason they have that job is because the surgeon is providing a service. And vice versa, that surgeon collaborates and makes sure that an anesthesia provider feels and understands that they are an important part of that team and that we understand that surgery couldn't proceed without them. So that layer of mutual respect has been huge.
So Garrett, same question to you regarding collaboration versus traditional negotiations. How are you interacting with your anesthesia providers?
I think collaboration is a great term to kind of surmise where we've come from. Previous to a couple of years ago, we had all medical direction. So we had 3 or more anesthesiologists as part of our team and had 100% medical direction since we were built in 2002. And so as the landscape has changed and shortages hit us here in Minnesota as well, the direction forward really was collaboration. So we are very thankful we have highly skilled CRNAs as part of our team. We really just increase the collaboration that we had previously in a medical direction only model. So we're able to adapt accordingly and collaborate with our CRNAs, doing some medical direction where it made sense, some supervision, but also independent practice. So we really did have a shift and change in the last couple of years due to some of the shortages happening across ASCs in the US. But I think just interacting with our anesthesia providers has just increased with more fluidity in our schedule and changes and shortages to cover our operating rooms. So I think the consequence of some of these changes has been positive in just proactive communication, dividing and conquering, really how do we meet the needs of the center and the patient, and really have increased the communication and collaboration within the team. And then in turn have seen a positive improvement in that quality care. Just forcing a team approach has really put everyone's focus on the patient, which has really been a positive. Receiving 2 retirements is what changed our medical direction only practice, and inability to recruit really did make us change. So it was a forced change, but the team here has really done a great job to meet the challenge and really enhance the collaboration.
Garrett brings up a really important point. What Garrett's talking about there is making sure that all of your practitioners are practicing at the top of their license, of their licensure. And I've noticed that in all of our centers across the board, the most successful ones are the ones that have done that with all their staff. So with your anesthesia staff, absolutely. Allowing everybody to practice at the top of their licensure is huge. But even with the staff themselves, so your nurses, your surgical techs, things like that, each state's a little bit different. But as you allow each one of those people to practice to the top of their degree, it's interesting how even that will alleviate some of that anesthesia burden. Just to use an example, in some of my oral surgery centers, the oral surgeon has always done their own sedation. But in those, now we've got RNs that come in and can help that oral surgeon increase their volume, increase their speed, because they're now practicing to the top of their licensure under those oral surgeons. And then to Garrett's example, we've got CRNAs out of that care team model that are now in a collaborative model with physician anesthesiologists, each one practicing to the top of their degree, which has been excellent too with our physician anesthesiologists who are very skilled and talented people who really some of the time their talents were being wasted doing pre-ops only essentially and doing blocks only, who now are back in the chair doing anesthesia, providing excellent anesthesia, and then allowing the CRNAs that are also excellent practitioners to practice at the top of their licensure. And just really, that has been a great way to alleviate a lot of that stress.
Garrett, earlier you mentioned scheduling, and let's drill down on a couple of the more successful tactics that centers are using to mitigate these challenges you both have been discussing. How are your scheduling procedures and managing the payer mix of patients today versus 2 or 3 years ago?
I think that has been an efficiency gain for us as we've navigated the collaboration change with our anesthesia services. A few years ago, our schedule for 4 ORs was very open, and you schedule into your block time, of course, for the surgeon, but in more of a need to meet the needs with less resources from an anesthesia perspective, we've really been forced to change, and it's been positive, of course. Looking back, in the last couple of years, we really have forced efficient use of block schedule time. If we only have one case in a room, can we move that patient in coordination with the surgeon's office to maybe not need a temp CRNA to fill in? So really has forced creative use and the previous mentality of just schedule into my block. No, let's schedule efficiently. We can go a little longer because we can efficiently use our anesthesia team as well. And then back to our culture, we didn't just pack our ORs. It's how do we efficiently staff our ORs for the patient load that we have and also get breaks and not burn out, because that's just as important. We had a change and we also didn't want to lose any more people. We wanted to be the employer of choice. And so all of that kind of balancing act really did change. And probably for at least a good year, if not 2 years, that was a daily review. And that was a daily review with myself, representing administration and our board with the anesthesia team. What makes sense? What can we plug and play? Should we move a patient because we won't do justice to the day? Which, looking back, I think we only moved 1 to 2 patients over a 2-year time frame of adapting. So it really did force efficient use of that schedule. As far as payer mix, like I said, we had previously done medical direction only. We are an independent ASC, and so we do all of our billing in-house. So we're a little bit closer to the flame than if the management company were to do it. So we've constantly evaluated what makes sense, where our contracts line as far as where does it make sense to do medical direction from a payer perspective, with, of course, the caveat was we're making decisions based on patient care and outcomes. And then we can look at, is there tweaking that we can do from a payer mix perspective? So just really has forced a lot of good questions. And again, the word of the day, I think, is collaboration to make sure it's efficient for our team here at the ASC, but of course, ultimately facilitating an efficient day for our surgeon and the patients.
Garrett, one of the things that I hear most frequently about why physicians become owners in a surgery center or bring cases to a surgery center is the ability to take control of their day, to get their block, be able to build around their clinic time and their personal time to be able to make it work. And obviously, dealing with this anesthesia challenge, that's forced to change there. So how hard has it been to change kind of the viewpoint of your surgeons about having to be able to adapt their time in order to fit this more compact schedule to make better use of anesthesia?
I think that starting this endeavor of changing the model, the communication was key, specifically with our surgeons. And I'm fortunate from my perspective, and again, looking backwards, always clearer, but we had a lot of buy-in from our entire team. Starting with our board, our medical director, our entire physician leadership knew the challenge being handed. We now have 2 openings to fill in anesthesia services, and we have to adapt. There's no choice. And getting ahead of it, communicating, this is how we're going to handle it. We're going to efficiently schedule. Here's the data. Of course, data-driven decisions are helpful. We know that is one of the key benefits of having Mankato Surgery Center is to get cases on when and where the surgeon prefers them and what's best for the patient. But everyone had to adapt. I'm fortunate our surgeons were leading the way. The understanding of the alternative is not to schedule or wait till next week when we have an extra CRNA picking up. that's not ideal either. So a lot of understanding and communication was key. And this is what we're doing. We didn't just say no to your surgery that day. It's 10 o'clock doesn't work, but we can do noon, 1 o'clock, we'll fit it in and work around the parameters specifically from the clinician point of view. If, like I said, 2 patients had to reschedule to fit in our anesthesia care services, that's a direct conversation. That's me calling the surgeon, texting the surgeon, hey, this is what we're doing. This is where we're moving. Let me know if you have issues. And I think that's better well received.
Brett, similar question. What have you seen or experienced or counseled centers to do differently in terms of scheduling the payer mix on any given day when anesthesia services are required, which I assume is most days, and particularly from the perspective of that smaller facility?
What I'm seeing is exactly what Garrett described. So just increasing that efficiency and having to get that buy-in with the surgeons that are willing to make those adjustments. And we've done very similar things to what Garrett has done as far as trying to streamline things. Looking at overall scheduling usage of the anesthesia, one of the big things now is minimums. So every anesthesia provider or group has minimum hours. So if I'm covering for you that day, you have to guarantee me 8 hours. If you cancel this far in advance, you have to guarantee X amount of reimbursement, whatever percentage it would have been. And so one of the things we looked at in a lot of these centers was, okay, how efficiently are we using our anesthesia days? What's happening here? And so a lot of places would go in and look and say, okay, we've got these providers that each have a full day block, but they're really only using about 60 to 70% of that full day block. What if we consolidate those, give them an extra, we call it a potpourri day. So we have an extra day in the week where it's the freebie day, where it's, hey, if you've got more cases you need to get done that week and you can't get them done, just know we've got one extra day with one extra provider that we can sneak y'all in. A lot of that has been what's going on. Unfortunately, some of the smallest centers have had to really reevaluate cases they're willing to take to the facilities as well, which is unfortunate. It's not the thing that's best for the patients, unfortunately, and it's 100% driven by the insurance companies. And so 100% of the onus goes on them. But just for an example, I had one of my centers reach out to me the other day and say, hey, this gentleman really financially needs to be done at the ASC. The hospital's charging, it was something like 6 or 7 times what the ASC was charging. But his insurance would not cover the implant that was going in. And so the ASC stood to lose about $2,500 on the podiatry case because the insurance company wouldn't cover the hardware. And so unfortunately, that was one where we just had to say, hey, look, we have a really thorough pre-screening program as far as there has to be a pre-auth in place. We have to make sure that hardware is going to be covered by most of the places I work at. The policy is that we look at the CPT reimbursement. And as long as the CPT reimbursement plus a small percentage covers the hardware, then they're okay to proceed, whether or not we're going to have the hardware covered. So we look at that in almost all these centers first before we get going. And unfortunately, it has led to 3 insurances that I can think of off the top of my head that basically have just been eliminated for most of my centers, just due to their refusal to reimburse at an appropriate rate. And so that's been unfortunate. On the anesthesia side of things, again, just really streamlining, making sure that we're fully using their services when they're there. One of my centers was a hand center, and the surgeon would do 2 or 3 general anesthesia cases and then 5 or 6 local anesthesia cases. And we tried to help them understand, hey, look, you're losing money on anesthesia because we've got a guaranteed minimum for this person. So things like that, just going through and educating, a lot of education there, a lot of pre-surgical legwork to make sure that everything's going to be in place. We've taken historical data on each one of these surgeons and started scheduling their cases according to that as well. If you say it takes this long to do a bunion repair, but when we look back at your surgeries and it took this long to do your bunion repair, based on the historical data, that's what you get to schedule your cases for, not for what you think you can get it done. Again, just getting the buy-in there, helping them understand that ultimately this does help their bottom line, help keep us financially viable, help keep their distributions maximized as much as possible. We've been very fortunate to have really good buy-in pretty much across all of our sites across the nation.
It seems to me that in listening to both of you talk about this in terms of just how critical scheduling is as a component of all this, that it really requires a lot of communication, I imagine, between the facility and those physicians' offices who are scheduling their clinics and their patients for other things and trying to coordinate that. And that must be much more complex than it used to be. Am I right in that?
Absolutely. Yeah. And we jokingly say that all of our physicians' offices, that their office managers have our billing office on speed dial. Because really, a lot of times that's what it comes down to is, hey, is this going to be covered? Can we do this there? Perfect. Can we squeeze it into this day? Perfect. A lot more than it used to be. Times change and we have to roll with the changes.
Garrett, do you agree on that?
Yeah, absolutely. I think I say we have a lot of safety nets, lots of safety nets to coordinate that accurately before they get to our door. So yeah, definitely a strong relationship with our physician offices is key.
Brett, Garrett, I want to thank you both for spending some time with me today, as well as your willingness to provide an even more in-depth panel discussion at the upcoming meeting in May. I think it's going to be very well attended based upon just the really interesting things you've had to say today. So again, thank you for being on the podcast.
My pleasure. Thanks.
Yeah, thanks for having us.
Before concluding, I would once again like to acknowledge the support of our podcast sponsor, Surgery Partners, a leading owner and operator of ambulatory surgery centers with more than 200 locations nationwide. Surgery Partners collaborates with ASC leaders and physicians to acquire, develop, and optimize surgery center operations and helps ASCs scale efficiently, strengthen performance, and drive long-term growth. To learn more, visit surgerypartners.com.